Bachelor of Secondary Education major in General Science. Today we are going to have a short microbiology and parasitology lesson about parasites. Now, what is parasite? A parasite is an organism that lives on or in a host organism and gets its food from or at the expense of its host. There are three main types of parasites. The protozoa, a single-celled organism that can only multiply or divide within the host. The helminths, these are worm parasites. And the ectoparasites, these live on rather than in their host. Is parasite harmful to humans? It's fair to say parasites are generally bad for their host. Many cause disease and death so, like most species. We humans usually try to avoid infection at all costs. But it turns out that some parasites, although potentially harmful in isolation, can in fact help those hosts to cope with more deadly infections. But today, we are going to talk about 3 harmful parasites. But before that, let's have a game. All you need to do is guess what type of parasites I'm going to flash on the screen. Is it a protozoa, a single-celled organism, helminths, a worm parasite, or an ectoparasite that lives on the host, meaning lives from outside the host? Now, let's start. Number 1 is fleas. Where do you think fleas belong? Is it from protozoas, helminths, or ectoparasites? The correct answer is ectoparasites. Number 2. Where do you think tapeworm belong? Is it from protozoas, helminths, or ectoparasites? The correct answer is from helminths. How about Balastidium? The correct answer is protozoa. Number 4, flukes. The correct answer is from ectoparasites. How about roundworm? The correct answer is helminths. And last, the Giardia. Where do you think Giardia belong? The correct answer is protozoa. That's it for our guessing game. Did you get all the correct answers? Sana all, right? Now we are going to discuss 3 harmful bacteria. Their taxonomic classifications, morphology, life cycle, their hosts, epidemiology, transmissions, pathogenesis, diagnosis, treatment, and prevention. This is going to be a brief discussion, so stay cool and just watch and learn. Now let's start with Ancylostoma duodenale. Ancylostoma duodenale belongs to the kingdom Animalia, phylum Nematoda, class Serenantia, order Strongyloida, family Ancylostomatidae, genus Ancylostoma, and species Ancylostoma duodenale. They are small and cylindroidal in shape. They are pale pink or grayish-white but may appear reddish-brown due to the ingested blood. The body is curved with the dorsal aspect concave and the ventral aspect convex. The anterior end is somewhat narrow and bent dorsally in the same direction of general body curvature. This cervical curvature gave it the name hookworm. The male worm is 8 to 11 mm in length and 0 to 4 mm thick, while female is larger, having 10 to 13 mm long and 0.6 mm thick. Eggs are oval or elliptical, measuring 60 micrometer by 40 micrometer. Sexes are easily differentiated by their size, the shape of the posterior end, and the position of the genital opening. Ancylostoma duodenale, or also known as hookworm infection, begins when the worm is in the larval stage. The infection stage of hookworm is known as filariform larva. It penetrates the skin and migrates during its life cycle through the liver and the lungs, and it attaches to the mucosa of the small intestine. The larva matures into adult in the small intestine, where the female worms may produce several thousand eggs a day. The eggs are released into the feces and live on soil. Embryonated egg on soil hatch into juvenile 1 stage and mature into filariform larva. It starts a new reproductive cycle. Then the filariform larva penetrate and expose skin of human hosts, usually of that foot by the sweat glands and hair follicles. They invade the lymph and blood vessels, reach the lungs, and pass up the respiratory tract to reach the mouth. In mouth, it is swallowed by the host, which is the small intestine. Hookworms deplete the body of nutrients, and a major effect is severe chronic iron deficiency anemia. For the host, Ancylostoma duodenale is the most common dangerous parasitic roundworm causing serious infections in humans. For epidemiology, it is common in the tropical, subtropical, and temperate region of Asia, Africa, Europe, the Pacific Islands, and the southern states of America. For transmission, the most common and frequent way in which this parasite is transmitted is to walk barefoot through contaminated terrain in which there are infected larvae or microfilarvae. The second, less frequent form of contamination is through ingestion of food contaminated with the larvae. Hence, the importance of maintaining good hygiene when preparing meals. Ancylostoma duodenale is the causative agent for the disease ancylostomiasis or hookworm disease. Symptom of ancylostomiasis start with a ground itch occurring during the penetration of skin by filariform larvae. Cutaneous migration of the larva result in itching, burning, erythema, edema, and vesicle formation. Pulmonary inflammation and minute hemorrhage are associated with lung penetration. Diagnosis of infection by Ancylostoma duodenale is based mainly on the identification of eggs in the feces of the infected person. However, complementary studies such as the determination of anemia and eosinophila can also help to make a definitive diagnosis. The doctor may go to perform a blood test which specifies the leukocyte count. A person who is undergoing an infection by this parasite will present an increase in its number of eosinophils. In the skin level, we have erosions, erythema or redness, pruritus or itching, and appearance of papules. For intestinal level, we have diarrhea, nausea, vomiting, increase in the amount of gas, and flatulence. For pulmonary level, we have small hemorrhage, inflammation of the pharynx, and in some cases with bloody expectoration. And in the cardiac level, we have the appearance of heart murmur, electrocardiogram with abnormal results, and abnormal increase in the size of the heart. The most common prescribed drug is albendazole. If this is not prescribed, they may prescribe mebendazole. Both have the function of eliminating adult parasites and their larvae through different mechanisms. Likewise, it is possible that the doctor also prescribes some iron supplements in order to correct the underlying anemia in the clinical picture. The best way to avoid hookworm infection is not to walk barefoot in areas where hookworms is common and where there may be human fecal contamination of the soil. Also, avoid other skin contact with such soil and avoid ingesting it. Infection can also be prevented by not defecating outdoors and by effective sewage disposal system. Next, we have Ascaris lumbricoides. Ascaris lumbricoides belongs to the kingdom Animalia, phylum Nematoda, class Phasmida, order Ascaridida, family Ascaridoidea, genus Ancylostoma, and species Ascaris lumbricoides. Ascaris lumbricoides is elongated, cylindrical, and gradually tapering at both ends, the anterior end being slender than the posterior. It is the largest size of nematodes. It shows sexual dimorphism, or sexes are separate. The female measures 20 to 40 cm in length and 4 to 6 mm in diameter with a straight tail. The male is smaller, measures 15 to 31 cm in length and 2 to 4 mm in diameter with a ventrically curved tail. The cuticle covering the body surface bears a mini transverse striation, giving a worm's pseudo-segmental appearance. Generally, the nematodes have no color. The freshly excreted worm is yellowish pink in color, which gradually changes to white. Adult worms live in the lumen of the small intestine. A female may produce approximately 200,000 eggs per day, which are passed with the feces. Unfertilized eggs may be ingested but are not infective. Larvae develop to infective fertile eggs after 18 days to several weeks depending on the environmental conditions, optimum moist, warm, shaded soil. After infective eggs are swallowed, the larvae hatch invade the intestinal mucosa and are carried via the portal, then systematic circulation to the lungs. The larvae mature further in the lungs for 10 to 14 days and penetrates the alveolar walls, ascend the bronchial tree to the throat, and are swallowed. Upon reaching the small intestine, they develop into adult worms. Between 2 to 3 months are required from ingestion of the infective eggs to oviposition or egg production made by the adult female. Adult worms can live to 1 to 2 years. Humans and swines are the major hosts for Ascaris lumbricoides. Natural infection with Ascaris lumbricoides sometimes occur in monkeys and apes. Ascariasis or Ascaris lumbricoides plagues more people in the world more than any parasitic infection. Some estimate that as many as 1 to 1.5 billion people, or approximately 1 out of 4 people, are infected with Ascaris. In some tropical areas, 100% of the population have Ascaris. Ascariasis tends to occur more commonly in places where sanitation is minimal and human feces is used to fertilize our crops. As a result, the majority of Ascaris infections are concentrated in the developing world. Approximately 59 million people are at risk of morbidity or clinical illness from Ascaris. Ascariasis is transmitted by accidental ingestion of Ascaris eggs through contaminated food, water, or soil. Once the eggs are swallowed, they are passed into the intestine where they hatch into larvae. The larvae migrate through the body and into the bloodstream where they can cause severe coughing and wheezing. We have 2 phases. Phase 1 is the migrating larva. The migrating larva causes pathological lesions. The severity of lesions depends upon the sensitivity of host, nutritional status of host, and number of migrating larvae. During migration and molding through lungs, larvae may cause pneumonia with low-grade fever, cough, and other allergic symptoms. For phase 2, which is the adult worm, few worm in intestine produce no major symptoms but sometimes give abdominal pain, especially in children. Large number of adult worms affect the nutritional status of host by robbing the nutrition, leading to malnutrition and growth retardation in children. Lumbricoides also produces various allergic toxins which manifest fever, conjunctivitis, and irritation. First is we have detection of parasites. In the case of heavy infection, the adult worm is possible to find in stool or sputum of the patient by the naked eye. Next, we have microscopy. The saline emulsion of stool is examined microscopically for the presence of eggs. Both fertilized and unfertilized eggs are usually present. We have also blood examination. A complete blood count may show eosinophilia in the early stage of invasion. Others, we have ultrasounds, CT scans, and X-rays. In the lungs, signs and symptoms similar to asthma or pneumonia, including persistent cough, shortness of breath, and wheezing. After spending 10 to 14 days in the lungs, the larvae travel to the throat where you cough them up and then swallow them. In the intestines, in mild or moderate scariasis, the intestinal infestation can cause fog, abdominal pain, nausea, and vomiting, diarrhea, or bloody stool. If you have a large number of worms in the intestine, you might have severe abdominal pain, fatigue, vomiting, weight loss, or malnutrition, and worm in your vomit or stool. Anthelmintic medications or drugs that remove parasitic worms from the body, such as albendazole and mebendazole, are the drugs of choice for treatment of Ascaris infections. Regardless of the species of worm, infections are generally treated for 1 to 3 days. Of course, the best defense against Ascariasis is good hygiene and common sense. Follow these tips to avoid infection. First, practice good hygiene. Before handling food, always wash your hands with soap and water. Wash fresh fruits and vegetables thoroughly. And use care when traveling. Use only bottled water and avoid raw vegetables unless you can peel and wash them. Last but not the least, we have Aspergillus species. Aspergillus species belongs from the kingdom fungi, phylum is Comycoda, class Eurothiomycetes, order Eurothiales, family Trichochomacea, and genus Aspergillus. Aspergillus was first catalogued in 1729 by the Italian priest and biologist Pier Antonio Micheli. Viewing the fungi under a microscope, Micheli was reminded of the shape of an aspergillum or holy water sprinkler, from Latin spargere, to sprinkle, and name the genus accordingly. Aspergillum is an asexual spore-forming structure common to all Aspergillum species. Around one-third of species are also known to have a sexual stage. While some species of Aspergillus are known to cause fungal infections, others are of commercial importance. Aspergillus species are predominantly saprophytes, growing on dead or decaying matter in the environment. The infectious life cycle as Aspergillus begins with the production of conidia or asexual spores that are easily dispersed into the air, ensuring ubiquity in both indoor and outdoor environments. The primary route of human infection is via the inhalation of these airborne conidia, followed by conidial disposition in the bronchioles or alveolar spaces. Humans are the major host of Aspergillus sp. Aspergillus sp are found worldwide and widely distributed in the environment. Aspergillus sp are rare causes of disease in humans and occur primarily in immunocompromised individuals. Invasive infections caused by Aspergillus sp have been associated with high rates of morbidity and mortality, especially in immune-compromised individuals such as transplant patients. The incidence of invasive Aspergillus in patients with acute leukemia was reported to be 12.7%, with a death rate of 13% in the year 2006 in United States. Compared to 2003, the mortality associated with invasive aspergillosis in acute leukemia patients has decreased from 24% and the incidence has increased from 5.8%. Inhalation of airborne conidia through contaminated water or exposure to conidia during showering and nosocomial infections or hospital fabrics and plastics may serve as important source of Aspergillus sp. Aspergillus species are well known to play a role in 3 different clinical settings in man: opportunistic infections, allergic states, and toxicosis. Immunosuppression is the major factor predisposing to development of opportunistic infections. These infections may present in a wide spectrum, varying from local involvement to dissemination and as a whole called aspergillosis. Among all filamentous fungi, aspergillosis is in general the most commonly isolated one in invasive infections. Healthcare providers consider medical history, risk factors, symptoms, physical examinations, and lab tests were diagnosing aspergillosis. Imaging tests such as chest X-ray or a CT scan of lungs or other parts of the body depending on the location of the suspected infection. If the healthcare provider suspects that you have an aspergillus infection in your lungs, he or she might collect a sample of fluid from your respiratory tract to send to a laboratory. Healthcare providers may also perform a tissue biopsy, in which a small sample of affected tissue is analyzed in a laboratory for evidence of aspergillus under a microscope or in a fungal culture. A blood test can help diagnose invasive aspergillosis early in people who have severely weakened immune systems. Aspergillus species treatment includes oral corticosteroid drugs. Solid or liquid oral medications may be prescribed to treat allergic bronchopulmonary aspergillosis. These drugs reduce inflammation and prevent respiratory symptoms such as wheezing and coughing from getting worse. Some of the most common used drugs are prednisone, prednisolone, and methylprednisolone. Next is antifungal drugs. These medications are generally used to treat invasive pulmonary aspergillosis. Voriconazole is currently the drug of choice because it causes fewer side effects and appears to be more effective than other medications. Last is surgery. Surgery may be necessary in case when aspergillomas are present and cause serious problems such as excessive bleeding. Antifungal medications are usually not effective against aspergillomas, so surgery is recommended. Due to the prevalence of aspergillus mold in the environment, it is very difficult to avoid exposure. It is best to avoid locations with excessive amount of dust or mold, such as construction sites or compost piles. People with weakened immune systems or mold allergies should avoid activities such as gardening or lawn mowing. If exposure to airborne dust or mold is likely, considering wearing a face mask or N95 mask. In some cases, your doctor might recommend the use of an antifungal medicine to prevent infection. That's it for today. Thank you for watching this video. Stay safe and stay fresh. Bye!